Welcome to Series 2 of the Latte Lounge podcast. Join me, Katie Taylor, as we talk balancing hormones, busting myths, breaking taboos, boosting libidos, and bolstering confidence. Why not grab a coffee, take a seat, and join us in the Latte Lounge as we chat all things midlife, menopause, and beyond. With thanks to our friends at Clarins for making this podcast possible. Dr. Heather Currie is a gynecologist and founder of Menopause Matters, an award-winning website and quarterly magazine. As a trustee and past chair of the British Menopause Society, she is a driving force for women's health and menopause care, and the author of many reviews and original articles in peer-reviewed journals and books, with an MBE awarded in 2021 for services to healthcare. So welcome, Dr. Currie, and thanks so much for joining me today.
Very welcome. Thank you for the invitation.
So I was wondering if we could just start by looking at, first of all, what happens to our menstrual cycles as we age?
So our menstrual cycle is dependent on how well our ovaries are functioning. And to function normally and produce the right balance of hormones in an up and down kind of way, there have to be plenty of egg cells within the ovary. So the maximum number of egg cells are there before we are born, so they've already decreased by the time we're born. And gradually over the years, the egg cells become lower in number and quality. So the key important thing is that the ovaries, when they have functioning egg cells, which are developing each month, which lead to ovulation, and that can obviously lead to pregnancy in some situations, then along with that, the ovaries are producing two important hormones, estrogen, in an up and down way throughout the cycle. And in the second half of the cycle, after the egg's released, known as ovulation, they also produce progesterone. And these two hormones have a significant effect on the lining of the womb, really making it ready to be thick and squidgy so it could receive that fertilized egg for implantation. However, at the end of the cycle, if in the absence of pregnancy, the area of the ovary that's producing these hormones collapses, the hormone levels drop, and hence menstruation or the period as a result. So periods really tell us what our ovaries are doing. And when we get to this time, what we know as perimenopause, when the quality and number of eggs is changing, the function of the ovaries changes. You also have feedback going on with a bit of the brain, the hypothalamus and the pituitary gland, and there's quite a complex cycle which leads to that normal monthly period. And when that response is changing and the ovarian function is changing, that's when we can see a change in our period pattern. And that might be the first thing that we notice before we start having the symptoms due to lower and lower levels of estrogen, such as flushes and sweats and mood swings. The change in the period pattern might be the first thing that we notice. And this is all happening in this time known as the perimenopause, which is when we're transitioning from normal cycles with normal functioning ovaries and plenty of estrogen to get to a point where the ovaries gradually produce so little estrogen that the lining of the womb isn't stimulated anymore, and hence periods stop.
And it's interesting, isn't it? Because so often, women and doctors assume that you're only going through menopause when you no longer have periods. And that word perimenopause, as so many of us know now, has never been mentioned before. And so for women listening who have a similar story to myself, you can struggle for years with all the other sort of psychological symptoms and perhaps, again, like myself, have no hot flushes. But because the only question, perhaps some of your doctors are saying is, well, you're still having periods, therefore you're not, menopausal. But that's when all the issues can actually occur. So you mentioned that, periods can get shorter, they can also get heavier. What is normal? And obviously, when should women be concerned? Because we do hear from a lot of women that they experience very heavy flooding, for example.
Yeah, so the common pattern is that often periods start to spread out a bit. And to lead to that regular bleed is dependent on that egg being released and the progesterone being produced in the second half of the cycle, which has a sort of regulating effect on the lining of the womb, and then it's shed. So when our ovaries are not working so well, often we miss ovulation. So we have what we call anovulatory cycles, which means that the ovaries are still producing estrogen, the lining of the womb is getting thicker and thicker, but we haven't had that effect on the lining of the progesterone and then the shedding. We might miss a month or miss a couple of months. So that in that time, the lining of the womb is building up so that when the bleed does come, it often is really heavy. And that's that common pattern in this perimenopause. Some women do find the periods become more often, but the times when we sort of most worry about it is the bleeding in between periods. So that's a bit of an alarm bell, really, that there might be something else going on. I mean, even if it is that pattern of periods spreading out and heavier, that can still be absolutely the right thing to be treating, because we shouldn't have to put up with that. And when we lose that pattern, it becomes unpredictable, so that the bleed can just appear at a random time when we're not prepared for it. If we're at work and we don't have any period products with us, or often they are now provided in workplaces, which is fantastic, but that awful sensation of suddenly you're bleeding when you weren't expecting it. When you have a regular pattern, it does give you more planning, so you can be more prepared. So there are lots of treatments that we can do. And as you said, often there are other symptoms going along with that. And just to sort of clarify, women have often been told in the past it can't be menopause because you're still having periods. And you're absolutely right. There's much more awareness now of this perimenopause. And the menopause itself means the final period. So strictly, that is correct, that actually, if you're still having periods, you haven't gone yet to the point of the final period. But we have much more recognition now and awareness that as a lot goes on before the final period. It's very unusual for someone to have completely regular cycle without any problems, and then suddenly periods stop, and a few months down the line think, oh, I haven't had a period for a while. There is often that crazy time in between when it's a gradual change.
Yeah, it's funny. I always think we should almost not even talk about the word menopause, because if it's a year and a day since your last bleed, I think everyone's so focused on that we're, I think far better to be, planning and aware of what can happen before. But before we go on to talk about sort of treatment options, what are the underlying sort of issues that might be causing things like heavy bleeding? I mean, for my own personal experience, it actually was something called adenomyosis, for example, which wasn't explained to me until I'd actually had a scan and we sort of were working out what was going on. But maybe you could sort of talk through a few of these different conditions, such as fibroids and adenomyosis.
Yeah, so the commonest cause in the perimenopause is that cycle changing, that whole control of the lining of the womb changing. Sometimes if the lining has been overstimulated by estrogen, and there are certain situations when that's the case. So for example, there is a condition called polycystic ovarian syndrome, which affects younger women, but can go on for a number of years. And what the problem there is a bit related to what I've just described. So it's having spells of producing estrogen, but not having the egg release, not having the ovulation. It's a hormone imbalance, and that can lead to a number of years of the lining becoming thicker and thicker. And that can eventually lead to the term is hyperplasia. So that's when it's an abnormal thickening of the lining of the womb. So that can be present if there is a history of polycystic ovarian syndrome. You mentioned fibroids. Fibroids are really, really common, and often they're present without actually contributing to the bleeding problem. So fibroids can occur in various positions of the womb. So if you think of the womb as a sort of upside down pear, and the middle bit where the core is where the lining is, and the fleshy bit that we eat is the muscle layer. So a fibroid might be completely within the muscle layer of the womb, and often they're very small. Often they're picked up by scans, because scans are requested so frequently that, when we're arranging a test, we have to think, what is the value of this test, and what is it going to change our management, our advice? Because if it's not, then don't do it. There's a lot of investigations carried out. So often what we see is a report where someone's concerned about them having fibroids, but they may only be, say, 2 or 3 centimeters completely in the muscle layer of the womb. They're not going to contribute to any bleeding or cause any other symptoms. The other place you can get fibroids is on the outer layer of the pear, on the outside. And again, that's not going to cause any problems. The type of fibroid that might contribute to heavy bleeding, is when it's on the inside and it's butting into the cavity of the womb. So the cavity itself can be a little irregular. But actually, sometimes the treatments that we offer can counteract the effect of that as well. Sometimes you might get a polyp that's like a skin tag in the womb. Again, this is something that often is picked up on investigation, but may actually not be the cause of the bleeding problem. That's more likely to cause bleeding, such as irregular bleeding, bleeding between periods. The other really important thing is the cervix. There can be problems with the cervix that can add to the bleeding. So the worst case scenario, a cervical cancer. So an examination should always be carried out if there is increased bleeding, increased frequency, particularly bleeding in between periods. Sometimes the focus is on the womb, but we need to also think, is there a polyp or could there be a cervical cancer that's actually adding to the bleeding? And we do sometimes see women who've not had an examination in whom we do pick up these changes. So the adenomyosis you mentioned, so that's linked to endometriosis. So endometriosis is where the lining of the womb, instead of just being in the lining, is found outside the womb or in the muscle layer of the womb. And that can sometimes make the womb a little enlarged and can increase the size of the cavity of the womb and can also contribute to bleeding. But also, we will go on to treatments. The hormonal treatments that we use can also be effective for these particular conditions.
And a lot of women, who are suffering this heavy bleeding also complain that they are becoming very tired. So obviously we all need to be aware that if this is an ongoing thing, that they could becoming, perhaps anemic due to perhaps losing a lot of blood and loss of iron. So, I mean, what would be your recommendation if you're, if you've been back and forth for your doctor, various conditions, what should be the next sort of, the next plan, so to speak, and then let's discuss treatment options.
So the next plan is, what are we going to do to manage this? And actually, I would encourage all women to be aware that actually there's nothing good about periods, whatever age, not just at the perimenopause. And there's so many now, so many women have this mindset that it's normal to have a period. And it's, if you do anything to stop it, then that is abnormal and it's going to cause problems. But the simplest thing, for example, is that women who take the combined contraceptive pill, which, often in the perimenopause, that can actually be really useful unless there's any medical conditions to see that as a risk taking that. But the combined contraceptive pill, which takes estrogen and provides estrogen and progesterone, traditionally has been taken in a cyclical way. So taken for 3 weeks and then you have your week off, which, hey, wonderful, you get your bleed in that week off. There's actually nothing sensible about that way. That was the way it was designed many years ago. But what we encourage, and anyone listening who takes a combined pill in that cyclical way, please be aware you can just put the packs together. There's nothing good, there's nothing helpful, there's nothing scientifically sensible about having that week off. All it's doing is recreate your cycle. And if you're relying on that for contraception, then taking it all the time is actually more effective for contraception, because the fertility part is the most dangerous time to miss a pill is at the start of a new pack. And if you're just a day or two late in starting, you think, oh my goodness, it's that day of the week I need to start a pill, then that's when actually your egg development can pick up, can wake up and can start. So from a fertility point of view, it's actually safer, more effective to take it all the time, and much easier to remember if you're taking it every day. So all that happens then, if you create these steady levels of hormones, the lining of the womb just stays as it is instead of going through that stage of being thickened and then shed. Whereas if you take it for 3 weeks, stop it, that dropping of hormones leads to the bleed. So for any women taking that pill, then you don't have to take it in that cyclical way. And we're doing a lot of work to try and encourage pharmacists, to try and encourage GP practices to recommend it in that way. But I know that many women still think, oh, that can't be right, that's not normal. It's actually absolutely fine. So let's have as fewer periods as possible. When it comes to that perimenopause, as I said, there is the combined pill that can be used. And actually, the other side, I mentioned contraception there, but we have very good contraceptives that can be used for the non-contraceptive benefits. So even if you don't need contraception, if you've been sterilized, if you're not in a relationship, if your male partner's had a vasectomy, You may think, well, I don't need to take a contraceptive pill because I'm not going to get pregnant, but actually you can use it because they're very good at controlling bleeding. There is a progestogen-only pill, desogestrel, which doesn't have the same sort of medical cautions as using the combined pill in our sort of late 40s, early 50s does, but you can use that at any age, and there are no real medical reasons not to use it. And that levels off those hormone ups and downs. So it suppresses your ovulation. So it suppresses those ups and downs, which are stimulating the lining of the womb. And that also can be very effective for controlling bleeding. We also have hormone releasing coils, which sit inside the womb, little plastic devices, which release the hormone progesterone directly into the womb. Really good contraceptive, but also really good control of bleeding as well. When we come on to thinking about HRT, we shouldn't use HRT to control bleeding. HRT is really effective for replacing estrogen and reducing the consequences and symptoms of becoming low in estrogen, which can still be happening in that perimenopause, but it shouldn't be used for the control of bleeding. We need to think about other ways of controlling bleeding in that situation.
And you mentioned the coil, so a lot of women will know the Mirena coil. It's something that we hear all the time is very helpful. And you touched on HRT. So am I right that that can also provide the progesterone element of the HRT as well?
Yes, exactly. And it's really helpful in that perimenopausal bit, because what it does is it provides the contraception, which is often needed. I've also mentioned you can use these for non-contraceptive benefits. It gives very good control of bleeding, and it also puts the progestogen directly into the womb. So with HRT, the main part of it is estrogen, because we're trying to replace the estrogen. That's what's gradually lacking. So that's what we want to top up and replace. But we also need to add in progestogen, or else estrogen on its own can do what I've been describing earlier. It can cause that lining to be thickened and eventually unhealthy. So unless someone has had the womb removed, had a hysterectomy, anyone taking HRT other than that needs to take that combination of estrogen and progesterone. And if you've got a Mirena coil in place, it can provide the progesterone part of HRT for 5 years. It would need to be replaced after that, or the HRT would need to be changed. But it can do that for 5 years, and it tends to minimize side effects. So with HRT, some women find the side effects of progesterone quite difficult to manage. Whereas with Mirena, the progesterone is concentrated on the womb. You get a little bit circulating, but it does minimize the side effects from the progesterone part.
So what for women who don't want to or perhaps can't take hormonal treatments, what other options are there?
Yeah, there is a preparation called tranexamic acid, which is non-hormonal, which is just taken at the time of the period. And the aim of it is to reduce the fragility of the little blood vessels within the lining of the womb. The usual dose is 1 gram 3 times a day, taken during the period and started when the period starts, not waiting until it's already heavy. That can be really helpful for women who, as you say, don't want to take hormonal therapy, which is a very reasonable view, but also they may not want to take something all the time. So the beauty of this, particularly for those women who still have a fairly regular cycle or cycle spreading out a bit, but it's heavy. And just to take it at that time can be a huge benefit for many women.
And are there any side effects or anything they should be looking out for? I know whenever you look in the packet, there's always some pretty scary words that you can sometimes read.
So it sometimes causes a little bit of nausea, and I think the recommendation is to take it with food to try and reduce that. If someone has a medical problem making them more at risk of blood clots, a deep vein blood clot, then it wouldn't usually be used in that situation. But for many, many women, it can be really helpful.
Yeah, that's really helpful. Now, what if nothing is helping at all? You mentioned hysterectomy, for example. Maybe you can talk through when things like an ablation or hysterectomy might be the most sensible solution.
Yes, so we do far less surgical procedures now than we used to many years ago, because we have so many good medical options. Actually, another one that I didn't cover there that can be helpful is if you're in your sort of late 40s, early 50s, and some of the medical things that we've suggested just aren't helping, but we've ruled out any other significant cause, then often what we can think about doing is actually switching off the ovaries. The ovaries have just gone a bit crazy at this time. And actually often women, I can't wait for the menopause. I can't wait for my last period. And actually we can use medical treatment to make that happen. We do need to advise that may lead to increasing of the increase of the estrogen deficiency symptoms. But then you can use what we call add back HRT. So you can switch off that crazy cycle that's going on and then add back HRT in a sort of steady way so it doesn't recreate the cycle. If even that doesn't work, and then we're thinking of offering something in secondary care in hospital, then an ablation you mentioned can be really helpful. So what an ablation does is it provides a heat treatment of different types into the lining of the womb and aims to destroy most of the lining of the womb as much as possible, because that's where the bleeding's coming from. It's the hormones and the crazy pattern that's causing the bleeding to line to the lining to bleed at different times. But so actually it wouldn't stop the hormones still being produced, or even if they're gradually decreasing, it wouldn't change that, but it would destroy most of the lining of the womb. So even if the hormones are being produced, there's nothing really much there to stimulate. That is sometimes done as an outpatient, but can also be done in a theatre setting. And the last resort now would be a hysterectomy, so with the womb being removed. And that might be more likely to be considered, for example, if there were large fibroids that were causing problems, if there was this adenomyosis problem that wasn't being managed in other means, if there was a lot of pain, for example, if there were these symptoms that couldn't be controlled medically, then a hysterectomy would be a last resort. So it is the one way of completely providing that reassurance that there will be no more bleeding. But there are lots and lots of options which will suit many women before getting to that point of having the womb removed.
Yeah, absolutely. And I know for a lot of women, I mean, again, I keep bringing my own story back in, but I ended up needing to have that hysterectomy because of my own adenomyosis, and it can be very devastating. And for some women, they may need to have it through possibly, we touched on cancer, and I will briefly talk about that in a minute. But when you're having your ovaries removed, we've discussed that will then plunge most women into a surgical menopause. So what words of advice would you give to anyone before surgery in terms of discussing things like estrogen, and also there'll be a lot of women who may not have completed or even started a family during that time?
So to consider a hysterectomy in someone who hasn't completed the family is an absolute last resort. But some women have such terrible symptoms that they're prepared to go ahead with that. The other thing to mention is you don't always have ovaries removed at the time of a hysterectomy. So it depends on your age, it depends on the situation for which you're having the hysterectomy. If you have your ovaries removed at the same time, that should be absolutely fully discussed beforehand, because there are huge implications if you are pre or perimenopausal, because your hormone balance is going to change suddenly. So with the ovaries removed, your estrogen level, even if they were gradually decreasing, is going to suddenly drop. If you have your ovaries removed at a time when you've had normal cycles, so normal ovarian function, and there's been some structural problem leading to surgery, then you're producing reasonably high levels of estrogen, which suddenly drop, and that surgical menopause can lead to quite severe symptoms very quickly. Sometimes within a few days, women start experiencing flushes and sweats and different changes. So to do that has to be absolutely fully discussed beforehand. Again, before going home from hospital, and given very clear advice about what the options are after that. If you don't have your ovaries removed, we do know that the time of surgery can sometimes affect the blood supply to the ovaries. So we know that women who have a hysterectomy but still have the ovaries may have reduced ovarian function at an earlier age than normal. And the difficulty there then is that they don't have any period pattern to link it to. So they won't, if you have starting to have menopausal symptoms and your period patterns changing, then you put the two and two together and you kind of understand what's going on. But that isn't the case when you've had a hysterectomy, so there's no period pattern. So it's really important to women to know what to look out for. And if they are younger than 45, then possible that they may have early menopause or premature if it's under the age of 40. And for these women, it is essential that they know what to look out for and report symptoms, because it's really important that they are offered hormone therapy unless there's an absolute medical reason not to, and to take it at least until the average age of the menopause, because we know there are long-term consequences of having an untreated early menopause.
Yeah, and I can't stress enough how many women we've heard through our Facebook group community who've not been told at all pre-surgery that they can be plunged, into menopause, especially when they've lost their ovaries, and some women get to a very dark place and suffer severe depression as well as all the other things. So, to anyone that's listening who perhaps is thinking about having surgery, please, please, please do discuss hormone therapy before you have that surgery. Now, we talked briefly about cancer, and I do want to touch on that. We as a platform support the Eva Peel, which is the UK's leading gynecological cancer research charity. And so I'm always very keen to sort of make people aware of what's not normal. So bleeding post-menopause, can you talk a little bit about that and when people should perhaps be concerned and get it checked out?
So if your periods have been stopped for at least a year and you then have bleeding, that absolutely should be reported. If it's within the first couple of years or so, then actually sometimes women will say, oh, it just feels like a period. I just felt like, with the same symptoms beforehand, sometimes the breast tenderness, the bloating. And often, actually, that is the case. We do know that sometimes these ovaries, the naughty little things, just have a little flurry of activity and produce some hormones. And we often, some women may have been having the symptoms of being low in estrogen, and then they realize that they go, and then a period comes. And so that is fitting in with your ovaries just producing hormones again, but it should still be investigated. And often you would be referred to secondary care. It depends on your local pathways as to what investigations are carried out. That's when a scan may be helpful, because we know in the post-menopause, the lining of the womb should be thin. It's not being stimulated because there shouldn't be any hormones around then. And they can do a measurement of the lining of the womb, and also would look for other things like fibroids, as we mentioned. So any bleeding after at least a year without periods, in the absence of hormonal therapy that's causing the change, then should be absolutely reported. Bleeding after sex is quite an important symptom. So if that's occurring, that's often due to a really simple situation, such as on the cervix, you can have a fragile area called an ectropion. You might have a cervical polyp, a little skin tag that I've mentioned before, that often can be quite fragile. But for that, you would need to have a vaginal examination, and that horrible thing we call a speculum. In my lay terms, I normally say that stretchy thing, because someone needs to actually look at the vagina and look at the cervix. And the vagina is important in the postmenopause as well. So often especially if you're not taking hormone therapy or not using vaginal estrogen, the vagina can be really thin and fragile. And that can cause postmenopausal bleeding and can cause the bleeding after sex and during sex. And so someone actually needs to look at it to make that diagnosis. So any of this type of bleeding should be reported. We mentioned earlier, when you're still having periods, bleeding in between periods, or if you've had one of the reasonably effective medical treatments and it hasn't worked, then that's another reason to look into, is there something else going on? And with all cancers, the earlier that it's picked up, then the more successful is the treatment. So it's really important to seek help.
Absolutely. And in our show notes, we'll leave some details on where you can read more about the Eva Pill, and they also have a free nurse-led helpline if you are concerned. I really recommend you ringing them. Now, before I let you go, I just have a couple more questions, because these are things that come up again and again and again in our community. There's a lot of women who are suffering, have been referred for a scan, and then can be sitting there for 2 months with nothing helping. So,
I mean, I did say a bit there about scans, because we do too many. There are far too many done. And, if someone is presented with heavy bleeding and they've had an examination and there's no pelvic mass or tenderness, then you don't need a scan. Just get on and off of treatment, because all that time she's waiting for the scan and then for the result, she's not getting treatment. So she's still getting the same problem. So in the sort of, we follow there was a nice guideline on heavy menstrual bleeding, and the scan comes if there's suspected a structural abnormality. No, it's not a first line thing, because what are you trying to do? We mentioned fibroids, but often they're so insignificant you wish you didn't know about them, because people do worry. If we've excluded a cervical or vaginal cause and we're thinking the lining of the womb, to measure it when periods have stopped is really helpful. But to measure it when you're still having periods is so unhelpful, it's just not worth it, because it's going to thicken and then shed. So it completely depends on where you measure it in the cycle as to what. There isn't a sort of normal cutoff at different points in the cycle. So it's not worth doing it for that. If we're really worried about the endometrium from the history or from the past history, past history of polycystic ovarian syndrome, or if someone's very overweight, that's more likely, then you need to sample it or look at it with a little telescope. You don't need to scan it. You need to actually get a sample of it. So there's a lot of misinformation. There's a lot of inappropriate investigations instead of just getting on and offering treatment.
Yeah. What is PMDD, and also when is it not normal? The level of pain that we're prepared to put up with. It's quite remarkable that we assume that all pain is just, oh well, it's just women's pain and I'll just have to deal with it. But when should we not put up with it? And also, what can we do about pain?
So the pain first. So anything that's causing you trouble, that's causing you distress, and that's going to be different for everyone. It's the same as what is heavy bleeding. Years ago, they did studies and they got people to collect their period products, and then they were weighed and they measured how much blood was actually in a normal period. But actually, a normal period for someone may be horrendous, and a really heavy flooding period may be seen as normal for someone else. So we're all different, so it's anything that is causing you trouble and is troublesome, then that is worth discussing. So it's difficult to measure pain, but we're all different and we all deal with things in different ways. We have to individualize. You mentioned PMDD, so that's premenstrual dysphoric disorder, a severe version of premenstrual syndrome. And actually that is important in the perimenopause, because I've talked about when our ovaries are changing, hormone levels are fluctuating, and you get these bigger fluctuations. And the premenstrual symptoms are led by these triggers from these hormone levels fluctuating. So the receptors for estrogen, particularly, and progesterone throughout the body, they interact with brain chemicals, with parts of the brain that control our mood, our anxiety, and interact with our bowels. So often we get bloating before a period, and sometimes but slow bowel movements, constipation, and then looser bowel movements after, aches and pains, and it's just a whole load of things. Hormones are responsible for so much. And when you have that fluctuation in the week, often leading up to your period, then that can trigger all sorts of changes. And so the treatment for that is a way of finding a treatment that suits you, that levels off those fluctuations. So a bit like controlling the bleeding in those heavy cycles, as I described before, you can use hormonal treatment to level that off. You can switch off ovaries. There's all sorts of things that we can do, but there isn't one way of dealing with this that suits everyone. So I guess actually what I've been talking about applies to menstrual related pain, to PMS, and to heavy bleeding, because if we can just stop this cycle or level it off, then that often is the answer for many women. But what can be really difficult is finding which preparation or which type of treatment suits each woman, because some women we can give a treatment that we know will level off these hormones and stop these cycles, but she may have side effects from that. So you then have to think again. The RCOG have a very good guideline on management of premenstrual syndrome that goes through different levels of treatment, first of all. And there's also nice guidelines on heavy menstrual bleeding. And there's lots of information out now about menopause and perimenopause and how we manage that. So we're in a much better place to be able to help women and women have much more information accessible to them. So hopefully things can only keep getting better.
Well, I hope so. So on that note, do you have any sort of top tips or words of advice for anyone who's listening to this, who is struggling with things like heavy or unusual bleeding?
I guess the main thing is bleeding isn't good, never was good, never will be good. So the more you can do to find out about what might suit you and to access treatments, as I said, even if you don't need contraception, there are lots of non-contraceptive benefits from some of the very safe, effective preparations that we have. Don't feel you have to put up with it.
Absolutely. Do not suffer in silence. So where can people find out more about you and obviously Menopause Matters?
I don't know if they'll want to find out more about me, but Menopause Matters is a very busy website. It's been around a long time. We do keep trying to tweak it and update it. We have lots of social media following with Instagram and Twitter and Facebook and TikTok and all these things. And we have a magazine which we publish quarterly, which is getting bigger and bigger. So the winter issue is going to have 116 pages, which is fantastic and very exciting. So I hope among all those things, there will be useful information.
Absolutely. Well, thank you so much, Dr. Currie, and all those social handles and the website and where you can find the magazine. We'll put in the show notes afterwards. But I really hope that everyone found that helpful. And if you're concerned, please do go and see your own doctor and get yourself sorted as soon as possible. So thank you again, Dr. Currie, for joining us.
Thank you.
Thanks for listening to the Latte Lounge podcast. Please subscribe wherever you're listening so you don't miss our next episode. For more support with all things menopause and midlife, head to our website lattelounge.co.uk and search for the Latte Lounge group on Facebook. This podcast was sponsored by Clarence and produced by Emily Crosby Media.